wanted to kind of hone in a bit on what many of you have talked about a little bit, which is kind of the nuts and bolts of day-to-day operations in the hospital. We can start with the operating room. A couple you've mentioned already. So I'd like to hear about what protocols people have in place regarding, first of all, how are you approaching any OR patient? A patient who comes in with appendicitis, are you operating on them? Are you more likely to do non-operative management than you would have been before? Are you testing them? If so, how long are you getting the results back within? Are they sitting in the hospital for 2 days while you're waiting for a test? If you're not testing them, are you presuming everybody's positive or a person under investigation and using full PPE? So we'll kind of start with that group of questions. How about Tony, do you want to start with those?
Sure, thanks. So we have not changed our practice in regards to operating on appendicitis. We still feel that that's the standard of care and that's how we approach it. But we've been really mindful about what SAGES is saying about that unknown risk of aerosolization with CO2 insufflation. So it's been hard. Following Adam's comments last week about universal screening for ambulatory patients, I've been working hard to try to get that implemented, at least on the children's hospital side, although the adults really like that idea and want to pursue that as well. We've formed an OR leadership committee. I'm the head of the pediatric side in terms of the surgeons, and in collaboration with the adult and anesthesia and the OR leadership, and go through the urgency or emergency of the ambulatory cases. In regards to the emergency cases, like the ER to OR cases, our ability to test for COVID is twofold. We do have in-house testing, but that's being saved right now for the high-risk PUIs. And so the in-house testing takes about 8 hours to come back for us. For the moderate risk, which I'd assume that the ambulatory patient population would fall into for surgery, that has to be sent to UW, or University of Washington, pardon me. And that turnaround time for us is probably going to be 24 to 48 hours. Although I will echo Dave's experience of taking several days when I personally got tested for COVID-19, which came back negative, but it was several days before I heard anything back. In regards to the emergency cases, our hospital still has the policy that we're treating it as modified droplet. So eye shield, regular surgical masks, gowns and gloves, except for the high-risk aerosolizing procedures like a bronchoscopy or intubation, in which case the first go-to are actually cappers. One of my partners operated in one of those, and it was a disaster. The entire shield fogged up, and they had to break through into that sterile environment to wipe out the shield, so that isn't going to work. Our hospital had stopped testing for N95s years ago. So another issue that has arisen as we're working to get fit tested is the lack of the solutions, the bitter and the sweet solutions that have to be used to be able to fit test N95s. Apparently that's also on shortage. So the surgeons are now deemed a high risk population and are going to be tested, but we have not been tested yet. And it begs the question about the recent JCO report that states we could bring in our own N95s from home. I don't know, our hospital hasn't addressed that yet one way or the other, but it is something that I'm personally considering. So that's kind of where we are in terms of surgical OR staff or processes.
Another quick thing to add to that list of questions is you mentioned obviously aerosolizing procedures are higher risk, and there are some places that for intubation in the OR are kind of doing that in a separate room or having everyone step out of the room and then wait a period of time. Have you changed any of your practices around intubation? And similar to in the OR, that could apply in the trauma bay and the ICU. Has there been any adjustment in the process around intubation in suspicious?
We have.
Positive, yeah.
Yeah, we have. We have a negative pressure room in the adult ACU, which we're utilizing for every intubation for a moderate or high risk patient. Not for every patient. If they're asymptomatic, we're still treating them as modified droplet, although some of us have reservations about that. Additionally, we happen to have an older OR that's not been functional for a while, but happens to have an anteroom. And so we're converting that into a second, essentially a staging room, and converting it from positive to negative pressure so that we are able to intubate an additional set of patients in that room. In terms of trauma, that's been a huge topic of conversation. And so we are looking at, we are using modified droplet precautions for every trauma. We're assuming every trauma is positive and treating them as such. And if they have to be intubated, then we're having conversations about having to either wear the full capper or N95 and moving the trauma patient over a couple of rooms down to our negative pressure room, although we have not come to an agreement on that yet.
Thank you. Dave Mooney, do you want to address some of that?
Yeah, I mean, I think what we're doing sounds pretty similar. The one thing that is just to add, after an aerosolizing procedure, including intubation in the operating room, no one can be in the room without an N95 for 30 minutes after intubation. So for a case, you're just going to wear an N95, unless it's a case that takes a lot, there's an epidural and 12 other things that would have prolonged anesthesia time. I don't know where that number came from, and I've heard different lengths of time that institutions are using for, the time that people need to stay out of the room. But it's really, there's a list of aerosolizing procedures, including, by the way, lower endoscopy has now been added to the list of procedures that needs an N95 mask. But again, we've tried to decrease the number of personnel in the room, not have trainees do intubations, have the attending staff do it. And it's very similar.
Art, what about you in New York?
Yeah, both our mayor and our governor have decreed that there should be no elective operations done. We certainly are standing by that at our institution. So no elective